Hey everyone, welcome back to part two of our lecture series on concussion. Part two is going to focus much more heavily on the examination of patients with post-concussion syndrome, which isn't a huge component of individuals with concussion, but there is quite a strong percentage of individuals that have persistent concussion symptoms for weeks, months, or even years post-injury. So this is actually, even though it's a smaller percentage of the individuals that have concussion, this is probably the majority of the patients you're likely to actually treat as a physical therapist. So with PCS, we have a couple of goals that we need to achieve with our examination process. Number one, we really need to confirm that the concussion is the appropriate diagnosis. Did they really actually have a concussion, or is there mixed symptoms that are coming from different diagnostic avenues? Okay. Secondarily, we want to identify the associated clinical profile. Because concussion, and in this case PCS, it involves such a wide array of signs and symptoms that it's really nice to be able to classify them in terms of, here's an area where they're having the greatest amount of symptoms, here are other areas that are contributing, and here are areas maybe that I don't need to focus on. If I can kind of organize my treatment plan for that person and kind of target the most significant areas first, and then work my way down to the secondary issues, I tend to see that a patient respond very favorably to the recovery process. So the clinical profiles are really going to be what helps set up your subsequent treatment planning for a patient. In regards to the subjective exam of a patient, be sure that you're doing a good job of understanding the mechanism of their current concussion injury, especially if they've had multiple injuries. You got to be able to delineate, how recovery went from the first impact to the second impact. You'll see quite a bit of patients with PCS that have had multiple concussions in their past medical history, and that always creates complications to their overall recovery process. Other important things, you want to know what their initial symptoms were on the concussion. Remember, we went back to some of those prognostic indicators. If that person reported significant dizziness after the injury or visual tracking problems, something along those lines, those create a poorer prognosis for that overall person. A prolonged recovery time is most likely going to happen for that person. Okay. Don't forget about some of those constitutional risk factors that might play a role in your overall prognosis for the patient, like gender, age, history of migraine, or other kinds of factors. There are quite a few subjective outcome measures that are indicated for somebody with PCS. Probably the two most commonly used ones, and ones that I would more highly recommend on this list, are actually the top bullet and the bottom bullet. So make sure you click on those links, work through the Rivermead post-concussion symptoms questionnaire and the concussion clinical profile screening tool. Those are your two probably go-to clinical measures. The Rivermead is kind of a nice one because it did play a huge role in how each of the clinical subtypes were generated, was based a lot on information drafted from this particular one. So this is kind of the hallmark of overall symptom rating scale for PCS. The clinical concussions profile screening tool is a little bit newer one, and I think it's a little bit more user-friendly and more commonly used today. So make sure you spend some time knowing those two particular outcome measures. As far as additional things with regards to your objective exam for someone post-concussion syndrome, don't forget how important vitals are going to be. As we've kind of mentioned before, one of your jobs is to make sure that you're ruling out any sort of serious injury beyond concussion-based presentation. So things like ruling out VBI or upper cervical instability, things along those lines are still going to be things you're going to need to do. Vitals can give you a ton of information about how healthy a person is to be able to move forward with the rest of your examination and your overall treatment plan. Neurocognitive assessment, the gold standard is the impact. We've talked about that a little bit before in the last lecture series. We'll cover a little bit more in detail today about the impact and what factors might be associated with that. Don't forget about other neurocognitive assessment tools. If you don't have access to the online impact tools, something like the MOCA or the mini mental state exam are also things that could be utilized for that particular assessment. You're going to need a very thorough differential diagnosis process for your neurologic exam. It's going to be just as imperative now as it was following immediate concussion to conduct a cervical examination, especially. Balance, you can see some of the special tests and measures. We'll cover some of those in lab and in this lecture series itself. Vestibular exam, a patient post-concussion might very well have significant vestibular findings. We will talk a little bit about oculomotor exams, in particular the VOMs. It's really something that we're going to highly recommend that you implement as part of your objective examination of a patient post-concussion. As we kind of talked about before, headache is the #1 most common symptom reported, and it's really important that you engage in differential diagnosis of their headache profile because there's a lot of different presentations of headache related to certain things. Migraine presents a very certain way. Cervicogenic is a fancy way of saying the headache comes from the cervical spine region. These are typically individuals that have increased headache symptoms associated with neck motions or sustained neck posturing. So really trying to make sure that you're doing a good job of figuring out what's the real source of that. Maybe it's the eye movements that are creating that. Maybe they have sinus drainage and they're having a sinus-based headache. Lots of things can create headache. Differential diagnosis becomes really important, and I know you're going to cover a lot of these things specifically in orthopedics content with regards to cervicogenic headache. So between what we're teaching here in neuro and what you're going to get in orthopedics, hopefully you'll feel pretty good about how you start to engage in a differential diagnosis of a headache management. Okay. Also, don't forget that mood assessment can be a really important component of things, especially if you have a pre-existing history of anxiety or depression or things along those lines. That's going to likely lead to prolonged recovery. But also remembering that concussion, especially if it's persisting for prolonged periods of time, that can really impact somebody's quality of life. And it's easy for individuals that are maybe used to a higher level of activity without restriction to maybe lose some of that independence because of these concussion symptoms. And so you'll see them start to develop maybe some anxiety or high stress or even some depression associated with just this prolonged recovery process. So make sure you're going to be checking in with some instrumentation to screen for things like anxiety disorders or depression. That patient health questionnaire, the PHQ-9, is a really good tool. It's quick and easy really to look at whether or not somebody has current symptoms of depression. If you have somebody with some significant findings on this mood assessment, just understand that the right course of action might actually be referral to another healthcare provider as opposed to incorporating it into your physical therapy treatment plan. Okay. Autonomic dysfunction is really common following concussion. Dysautonomia is something that you're going to have to be screening these types of patients for. It has been studied a lot more heavily in moderate or severe TBI. So we don't really know how exactly common it is, but just anecdotally, I can't stress enough about how much I've seen individuals post-concussion have real problems in being able to regulate their heart rate or blood pressure, specifically with exertion. So graded exercise testing, analysis of heart rate variability are strongly recommended. Buffalo concussion treadmill test is probably our go-to special test for dysautonomia assessment and exertional intolerance types of things. So we will actually practice doing the Buffalo concussion treadmill test as part of our lab skills component for this. So more to come on that. As far as autonomic dysautonomia goes, there's three major categories I'd like you to feel comfortable with. The first is actually on the far right. It's actually the one you're probably the most comfortable with or have heard before, orthostatic hypotension. Understanding that, typically we get symptom provocation when changing positions, typically moving from, supine to sitting, sitting to standing. Often we get symptoms from a drop in blood pressure. They may report dizziness or lightheadedness, fogginess, lots of those kind of key words. You don't typically see much change in heart rate, but you will see a significant drop in their overall blood pressure. So that's one common presentation that someone with PCS could present with. Okay, the one in the middle is POTS. It's a tachycardic based syndrome. So unlike the orthostatic hypotension, that's kind of referring to a drop in blood pressure, typically with POTS, you'll see a significant change in their heart rate. And it's diagnosed as greater than 30 beats per minute sustained increase when you move from a position of seated rest into a standing position. And we'll see that heart rate kind of spike up and then just kind of hold there for a period of time. Or you might see somebody with a sustained heart rate of greater than 120 beats per minute. You typically don't see a significant change in overall blood pressure. So those are two kind of opposing forms of autonomic dysautonomia that could definitely influence the way that person's able to handle functional tasks. The one on the far left is probably the most common, and it's some change or phasing between the other two, right? So it's not significant enough change that's consistent to call it tachycardic, and it's not enough to really state this is consistently orthostatic hypotension. Sometimes it's there, sometimes it's not. But typically you'll see symptoms happen with that change of posture from sitting to standing, and it improves when they lay down, and it's just not significant enough to meet the criteria for either POTS or orthostatic hypotension. So OI, orthostatic intolerance, is probably the most common type of dysautonomia that you're likely to see in a patient with post-concussion syndrome. Let's talk about some of the interpretation of these key outcome measures, a few that we've talked about before, or some that I want you to feel real comfortable with what they're measuring, how they're measuring it, what some of those findings might look like. Say, from a neurocognitive testing standpoint, I really need you to feel comfortable with what impact is, understanding that it's an online assessment, anyone can use it. If it's a sport-related concussion, the nice thing is that the trend these days is that the majority of those sports-related teams are doing more baseline testing of their athletes. So they have some sort of pre-existing level of cognitive function that they can compare if that person were to get an injury and they suspect concussion. Now they can use the results post-concussion to compare with their cognitive function on their pre-assessment, and if there's a significant enough change, then they can be a little bit more confident that concussion is present and make better decisions about, one, to pull the athlete out of play, and two, determine when that athlete might be more appropriate to return back to the field again. Okay, so the impact is strongly recommended for concussion, whether it's an immediate concussion or with post-concussion syndrome. It's highly valid, highly reliable, and it's going to be the most commonly used neurocognitive testing measure for this patient population. Just note that increasing age can be a factor related to variable performance on this test. In other words, the older the individual, sometimes it's difficult to determine if some of the issues or delayed performance that they're having cognitively, whether whether that's due to the concussion or just due to age-related decline. That's common for all of us. Okay, so for impact, there's a few different categories that they're looking at. They're looking at both verbal and visual based memory through the way that they do some of the computer tests. They look at reaction time, how quickly you're able to move your eyes to follow letters, impulse controls, and they do give you an overall total symptom score. So looking at some of the results, I just took some pictures of some of the results that I had from an individual who agreed to let us kind of talk through this. But what you can kind of look through is, on the left side here, it's kind of a summary of a baseline test for this individual. It tells you their age, when the test was done, and then it starts giving you the composite score. So when you kind of look at these boxes, some of them have two different scores. So the score that's on the left side, like for memory, composite, verbal, there you can see there's a 65. That's the overall composite total score they got for that component of their impact test. The percentage rate you see there is how that person compares with age and gender matched peers. Okay, so with that score of a 65, they're only hitting about 2% of what their normal peers would be functioning. So you really want a higher percentage number over here. The higher the percentage, the better that person is performing based on their peers scoring. Okay. So looking down at memory composite, the score is 74, but that percentage rate gives us a lot of good information about how they should really be doing based on everybody else. So 44%, they're doing the best that they can in the visual memory composite categories of any of the other ones that's listed there. So that's kind of their strength right now. But their strength is also much lower compared to what their peers would be performing. Okay, so each one of these kind of columns gives you some good information about that particular impact test, and then you can redo that test. You'll list the new date, so they, about 5 weeks later redid the impact, and you can base their scores on the second test to the first one to see what kind of recovery they've made from first to second. All right, so it really does help inform how your treatment interventions are going, how that person's going through the natural recovery process, and how they're coming along with being able to meet some of those age-related performance measures. Okay. What's interesting to report is that as we get kind of all the way to this far right corner, we had another concussion-based incident. So even though they were leaving off with pretty good scores on this second to last box, you can see a significant decline the next time. So now we have that situation where we can say, here's what their baseline was before concussion injury. We can see how much that next concussion has truly impacted their overall performance. Right. So this is a very similar thing on the right. It's just in a more of a visual presentation as opposed to the number. So basically these guys are saying the same thing, just in a very different format. With regards to balance, I do want you to feel comfortable with the BEST test. The balance error scoring system is highly recommended for this particular patient population. We will go over this in lab. But I would like you to take some time now to feel really comfortable about what the different positions are and what the directions are, so we can take less time in describing how to perform the test and actually just get to lab and do it. Okay, so read the directions, read through it, figure out how they determine errors. There's a lot of instructions about what constitutes an error. And essentially what you're trying to do is have them maintain this testing position, and you're just going to count the total number of errors for each one of those conditions. It could be moving their hands off their iliac crest, it could be opening their eyes, etc., etc. Each time they make that mistake, you're going to do a little like tally mark, and you're going to count up the, how many errors they make for each one of those testing positions. The max number you can get for each position is 10 errors. There's 6 positions total. So the maximum number of errors you can get would be a score out of 60. So it should make sense that the more errors means the poorer balance. So a lower score equates to better balance, and a higher score equates to poorer balance. Okay, it is very good, if not excellent, validity and reliability for the MTBI patient population. So this is definitely an indicated measure to use as you're tracking how somebody's doing. It is a little bit maybe lower level balance test. So if you have somebody with PCS that really has maybe a higher level of balance performance, and you really want to get them maybe to a higher level of athletic performance, then I would throw out the high mat, which you've already done in our lab coursework for this neuro course before. So I'm not going to take any time in class to go through it, but I do want to remind you about what the test is and how to implement this test, because it's really, really commonly used for this patient population. So review how to score it and what those findings might mean, so that you can use that to inform treatment planning for somebody that has balance deficits post-concussion. Ocular goes two major tests: the King-Devick test and the VOMS. The King-Devick is highly used in research. It is an easy to administer test. It has great data supporting its use. The problem with it is that it's not free. And what I will say that it's really helpful in order to help diagnose that there's an ocular issue and that person likely has concussion itself. But it doesn't have great research that that says it's a good measure to use to track somebody's progression. So the VOMS test is much more indicated because it has clinical utility in helping to reliably track how a patient is recovering with regards to their ocular motor issues. Okay, so again, better for detecting a concussion, but not really used as an appropriate outcome measure for progress in rehab. For that, I would highly recommend the VOMS instead. Now, it's not only an oculomotor screen, it includes vestibular components too. So the King-Devick is really more exclusively oculomotor assessment. But the VOMS will do everything that you need it to do. It'll be a great job of being able to identify what symptoms provoke issues with this particular person. There's lots of different tests that you can do that kind of give you a baseline idea of how they're functioning, and then be able to track how they're improving their tolerance to these particular movement patterns. So VOR is a huge component of it, visual motion sensitivity test. But some of the things that you kind of already know are great for oculomotor baseline testing, like smooth pursuits. Throw in your H-test there, looking at saccades both from a horizontal and a vertical standpoint, and a really, really hugely important category for somebody with PCS is to look at their near point of convergence. That near point of convergence is a really important component to help diagnose concussion and as a tracking measure of how they're getting along with it. So for near point of convergence, if they're greater than or equal to 5 centimeters and they've scored a greater than 2 on any other individual item, the likelihood that they're in a state of concussion is 94%. That's pretty good information there. The MDC for a near point of concussion is 4 centimeters, and that's really something that you want to track with most patients that have an oculomotor screening issue. As far as exertional goes, remember we talked about the Buffalo concussion treadmill test. Click that link, look through the instrument itself about what they're testing, how they're testing it, why they're testing it. Get a good feel for how to perform this particular measure, so that when we get to lab, we have enough time to actually test and go through it and go through some of the interpretation of results. Buffalo concussion treadmill test is really, really common to utilize with the PCS patient population. It has good prognostic value for acute concussion, and it's what we usually set as the most valid and commonly used outcome measure for exertional intolerance, which is something that's going to make a huge difference in tracking whether or not somebody's able to return to sport, return to work, some of those big picture decisions later on when a patient has exertional intolerance. How do I know when they can go back to the field and perform that sport or go back to work or school? The Buffalo Concussion Treadmill Test is that gold standard testing pattern to really help you make that decision. What we will say is it's not enough to use that solely in isolation. You should use that tool in combination with other outcome measures and symptom provocation type factors to make the decision to return to sport. So again, you're going to use that to help guide your decisions, but just not alone. And that's the end of part 2. So again, big picture things related to the examination of somebody with PCS maybe looks a little bit different than the patient that is immediate post-concussion, in that, maybe you're kind of focused a little bit less on making sure the patient's safe and appropriate to do further therapy with, making sure their C-spine is stable and ruling out, upper cervical instability or some of those things. But I just don't want you to forget that that's still a component that you need to make sure is okay. If you have any suspicions that they, still aren't doing things right, you do their cervical active range of motion and you're finding bilateral rotation limitations, don't forget that, Canadian C-spine rule of, hey, something's not right there. I don't like that. Let's look further into screening some of those big picture things so we don't miss something between their immediate concussion and their post-concussion syndrome. All right. Thank you for your time. And at this point, we'll go ahead and take a break. When you're ready, come back. We'll talk part 3, all related to clinical profile subtypes.